All these things also will be covered. So we are starting with this WHO call. We have done this time and again in this previous ones also, but reiterating the fact that WHO also recommends screening with vaccine with HPV. That's what it has been said, that 90% coverage with HPV vaccination for girls below 15 years of age. 70% is coverage of screening, that is 70% women screened with high performance tests at the age of 35 and 45. And 90% will be of, we have detected and we treat them. Then definitely there is a chance that we can achieve world free of cervical cancer. Their limitation call makes us understand that it should be less than 4 per 100,000 women having cervical cancer given at any incidences or any this thing in the population, any time in the population. So with this, we have this cancer control program with vaccination as a primary prevention. Secondary prevention is screening, treatment. Tertiary prevention is understanding the cervical cancers and then treat it, or palliative care. Now, talking about cervical, HPV. Now, today we are going to actually understand HPV in a in-depth perspective. It's not a broad perspective understanding. It's going to be an in-depth perspective. So HPV, we all know, is the root cause for cancer, almost at least. And we also know that 16 and 18 are the major cause for 70% of all the cervical or cancers or precancer. Now, what is an HPV? It's a papilloma virus. It's a small, non-enveloped epitheliotropic. Now, this is very important for all of us to understand. Epitheliotropic means it requires dividing cells to be active and to be alive, for that matter, and to even propagate further. It's a double-stranded DNA virus, it's mainly that infect the mucosa and cutaneous epithelium. Mainly, it is transmitted through sexual contact. And another thing to understand over here is you don't have to have a penetrative sex to understand HPV, to have that propagation. Even a skin-to-skin contact also should be fine. So here is the HPV structure, and you have got the capsids which are outside. Now, these capsomeres are the building blocks for, they have L1 and L2 capsid proteins. And these are the, L1 is basically used as the antigenic factor for building up vaccination, which are preventive vaccination. Now, there are a lot of studies going on for therapeutic vaccination also. And they are covering L2, and they are also taking E6, E7 into account for the antigenicity. Now, there is a double-stranded DNA. You can see over here. Now, this is the double-stranded DNA, which is in the ring form, episomal form. All right. So this is the structure. It's a small, non-enveloped icosahedral virus with 55 nanometer. Now, this is an HPV. It is written over here that at least 50% of sexually active people will have genital HPV at some time or the other in their lifetime. And you have the low-risk virus and you have the high-risk virus. Now, the genome, you can understand, is it has the late proteins, and it also has the early proteins. Now, each protein has its own role to play. Even in E2, usually are regulatory proteins, and E6 and E7, they are basically, this is the E6 and E7. They are basically the transforming protein. And you have this late capsid proteins, which is the cause for encapsulation and, release of the virus. And also this protein 4, E4 and E5. So E4 plays a role in virion release, and E5 is a hydrophobic protein that enhances cell immortalization. Let's understand that better. So that's your understanding 1618 and non-1618. And also we will understand that HPV per se is not only the cause for cervical cancer, but also for vaginal cancer, vulva cancer, genital warts, anal cancer, oropharyngeal cancer, penile cancer. So whenever you give a vaccination, invariably, these are the additional bonus points they get for other cancers as well. Now, I just said that there is an ORF or LCR over here. Now, whenever there is this, this is that open ring format. Now, this is that single DNA. So this is an open reading frame where we understand they can be divided into 3 functional parts. Now, this open reading frame is understood by the early region encoded by E1 to E7. Only E3 is not there. And the late one, which is responsible for L1 and L2 for virion assembly. And then there is an LCR. Now, this is the place where there is a splice whenever you want whenever there is a integrated HPV. So that's the splice happening over here. So what is an HPV? How does it help? So whenever there is a breach in skin, they enter, and HPV infects the basal cells initially. Why basal cells? And that too, basically in the SCJ region, the new SCJ. The new SCJ is the dynamic SCJ, dynamic portion. And it's an epitheliotropic virus. It requires dividing cells, and this dynamism actually attracts that HPV. And hence, you will see the lesions also arising from SCJ within the transformation zone. And we give a lot of importance to such lesions, and then that's how we understand a lesion on a colposcopy, and we take a biopsy also from there. So HPV initially is, let's say, maybe in a 10 copy numbers. Then there is a proliferation occurring. Then the genomic amplification goes to virion, might be 100,000 copy numbers. And then now you have to have this superficial cells laden with, now this is mature with a lot of virus, the superficial cell is laden. And you will be seeing a lot of coilocytic changes, which are the pathognomic features of HPV. And now for it to get released and the stabilized virus to release, you require L1 and L2 capsid proteins. So that's the assembly and the release. And what are the important thing? Let's see. So E6 and E7 are important cancer process. E6 will disrupt the suppress the tumor suppressive protein, that is P53. E7 will inactivate retinoblastoma protein. Understand, dear friends, P53 and retinoblastoma proteins are the tumor suppressive proteins. And I will be slowly taking you through that as well, so that you understand what exactly happens in the cellular level. And then E2 suppresses E6 and E7. So when I say that, E1 and E2 are regulatory protein, normally it tries to see that E2 suppresses E6 and E7, and it's kept at, at par. I mean, it only increases the multiplication, but it doesn't go into the tumorogenic ones. So they are actually sort of trying to keep a balance. But later on, then the balance goes away, and then E6, E7 comes up. So L1 is a major capsid protein, and L2 is a minor capsid protein. So here we have, so first is the infective stage, and then is the inflammatory stage, is when this, you can see this epithelium form of, this is a ring form of DNA. And this is called episomal form of HPV infection. This is here, there is an inflammatory reactions, local inflammatory reactions, like interleukin, or inflammatory, local inflammatory reactions getting released, and cytokines or interleukins, and there will be a lot of multiplication. Now this is the position where you get, might be it goes into SIN2, there'll be a lot of viruses, and slowly this getting changed, but still it is okay, it can regress, because it is yet it's in the form that is not got into integration. Then it goes into integration. I showed you LCR, that's the area where it splices, and it gets integrated into the host DNA, and thereby E6 is E7 is now expressing, and finally going into new virion or CIN progression. So we have this understanding that E6 it binds to P53, thereby degrading the P53. What does E7 do? It will disintegrate RB, and finally, get this RB on into phosphorylated RB. That is an E2F release, and cell cycle progression will occur. So this HPV infection comes with, normally you see this is the age chart, and this is the prevalence chart bar, and you will see that HPV has twice its peak. So, and simultaneously cancer also is increased in this age group. So they have understood one thing. This has come from the IPCO public release, and it was shown that 16 and 18 contribute to 70% of cervical cancer cases, between 41 to 67% of high-grade lesions, and 61 to 32% of low-grade lesions. After 16 and 18, the 6 most common HPV types are 31, 33, 35, 45, 52, and 58. Now, these account for additional 20% of cancer cases worldwide. And knowing that now this is from a normal cervical cytology in India, NILM, they found what is the HPV prevalence. And you can see HPV prevalence is still a little high. So I brought those figures for you, that whenever there is, this has come from this data, IPCO, and what they have seen is, what is the HPV prevalence of 16 and 18 in these cytology. So normal cytology is 5%, low-grade cytology is 28%, high-grade cytology 62%, cervical cancer 83%. And if you have to see into all the types of oncogenic, probable carcinogenic, or non-oncogenic types, let's see which are prevalent. So 16 and 18, and here we have this bar for normal cytology, low grade, high grade cervical cancer. So in a normal cytology, which are the HPV prevalence which they are seeing, which are seen? 16 is seen in 3.6%, 18 in 1.4%. Simultaneously, these are going down. Low grade may you have 16, 22%, 18, 6.2%. 31 is apparently quite high. You can see 51, 50, 15.4%. And 56 is also high, and 58 is also high. If you go to a high grade lesion, you have 16 contributing to 56.1%, 18 contributing to 6.7%. Now, 31 and 33 have their the same contribution to 3 and 6, and 51 to 10%. Now, then what's the prevalence in cancer? In cancer, 16 contributes to around 70%, 69.6, 18 contributes to 13.5, 31 to 2.3, 33 to 4, and 45 to 5.1. But in this probable carcinogens, so these are probable carcinogens, where 67 has a slight understanding in a low-grade lesion, and 82 in a high-grade lesion. So when overall, and then these are non-oncogenic HPV types, where you can see prevalence is quite low in a cancer, and otherwise also you don't see much. So what do you overall understand? If you take this 10 important 10 frequent HPV oncotypes in India, you will see in a normal cytology also you are able to get 16, 18, and this is it. In a low grade infection lesions also, HPV type 16 is showing 22, 31, 56, 58, and then 18 in a low grade infection. In a high grade infection, this thing of 16 is high, then 18 is also there, 51 is also there, 33 is there. Then cervical cancers, may you have 16 and 18 as a prominent features, then comes 45 and 33. And if you compare 10 oncogene in a cancer case, say squamous cell carcinoma and adenocarcinoma, overall in a cancer case you have this figure, and in a squamous cell carcinoma you see 16 as first, and then 18 is also there, subsequently 45, 33. In an adenocarcinoma, you will see 16 is there, but the 18 rates have increased. 31 is also increased, 33 is also increased, and unspecific type also. You have unspecific type where there is a squamo-columnar adenocarcinoma, sometimes mixed types also you see. So that is why we say that even if you are taking an HPV test with 16, 18 and non-16, 18, the non-16, 18 contributing to a very less account, even if you detect 16, 18, you do a colposcopy, try to understand the lesion and try to treat it. And if it is non-16, 18, and if it is PAP is showing less than ASCUS, you can just wait and try to, evaluate her after 1 year. You don't have to be in a big hurry to do a colposcopy. If it is ASCUS or more, if there is non-16, 18, ASCUS and more on PAP test, then you go for colposcopy. Now you see that we have gone a long way for HPV. 1949, the first visualization of HPV particles in human warts. Then in 1965, characterization of human HPV genome structure was seen. 1970s, Dr. Zur Hussain analyzed a possible role of HPV in cervical cancer development. Then in 1980s, the first 16 and 18 were isolated in a biopsy. 1990, discovery of high-risk HPV type as a main risk came to understanding. 2002 then came up the guidelines which included HPV genotype test or co-test or to triage it in cervical cancer screening. Then in 2006, the first bivalent vaccine got its FDA approval. 2007, quadrivalent vaccine got its, so Gardasil and then Cervix and Gardasil and quadrivalent also got its approval. Then in 2008, finally, Zur Hussain for his thing got his discovery, got that persistent of cervical HPV is the root cause for cervical cancer, got the Nobel Prize. Later, 2014, nonavalent was introduced and it got an FDA approval. And in 2015, you had ASSCP interim guidelines, including HPV genotype test for primary test TS, this thing also. So in a cell cycle, we understand that initially this is in senescence, G1 to S phase and T2 phase. Now, to keep it senescence, RB is always hypophosphorylated. That and if it has to have a cell cycle, the cyclin D and cyclin dependent kinases should have, they should connect. That this protein moiety should have a coupling, and that's how the RB gets phosphorylated, and the cell cycle starts. But then always it is in senescence, so you have CDK inhibitors, which is called INK4 inhibitors, which are the basis of IHC tumor marker P16 and all that. So they are always keeping decoupling this cycling dependent kinases. It is mostly decoupled, and hence for RB is hypophosphorylated. So this is this RB which is hypophosphorylated, and E2F is like attached. So there is no transcription factor for transcription. But whenever there is any lesion, and no, whenever there is an E6 and E7, and there is an activation of the cycling dependent kinases, this RB gets phosphorylated, E2F is released, and that's how there is a cell cycle. So that's a mechanism of a normal cell cycle transforming HPV infection to oncogenesis. So you have over here, this is what I told you, that when RB is phosphorylated by cycling dependent D and cycling dependent kinases, it releases E2F. Later, this E2F will go, it will trigger cyclin E, thereby stimulating HPV, the DNA replication, thereby progression. And the gene product, because of this, the P16, which is increased, this normally binds to, because it has a negative impact, like it doesn't want the cycle to get progressive or go into an immortalization. It wants senescence, it wants apoptosis. So how does it go? It will, the P16 will now go and bind with CDK4. It will inhibit the cyclin D, and that is why this inhibition of the complex of cyclin D and CDK4, it will prevent that phosphorylation, repeated become hypophosphorylation, thereby cell cycle inhibition. So this is what is, but in a mitosis, what happens? Mitosis also same thing happens, but here the P16 is that check, and P16 then decelerates it. It causes that, PRB decouples from E2F, thus turning on the cell cycle. As a result, mitosis occurs. Following the division, P16 is expressed at a low level, but it cannot be detected on a IHC tumor marker. It doesn't, because it is at the low level, and it will again facilitate the rebinding of PRB to E2F. So now this E2F again will be taken up, and that's how this cell cycle is put at rest. But what happens in a tumorigenesis? Tumorigenesis, this PRB is, this E7 will go and bind to PRB. Thereby, this E2F is permanently released, and then there is a on position. There is an P16 overproduction, which can be understood by tumor marker when we apply this IHC, and we will see brown stains in the cytoplasm. So P16INK4A by IHC method has a greater concordance with the histopath, and it's a new gold standard which they are using. And this is what exactly is written here, how the P16 mechanism acts. So you have this tumor marker as IHC tumor marker as P16INK4A and Ki67 using the brown thing, the cytoplasm, which shows that whether your SIN2 plus cases, are they going into further, integrated state, or are they further going to progress, or is it going to regress out? If there is no IHC tumor marker, is not having any that stain, so you can say that, okay, this case will regress and it will not go into progression. And this Ki67 is usually seen in any of the proliferation, so maybe even in a mitosis. Only in a cell cycle senescence, there won't be any this thing. So normally this Ki67 doesn't have much of a sensitivity and specificity. It's P16INK4A. I usually do a P16INK4A. I've been repeatedly doing it for my tissue biopsies and trying to understand whether this tissue is going to go further into bad prognosis. So this is how it is. And just a minute. Yeah, sorry. So a co-expression of P16 Ki67 indicates cell cycle deregulation, hallmark of transforming HPV infection. So now you have over here screen by HPV DNA or by 1618. You triage with P16 at Ki67 to indicate whether there is a presence of transforming HPV, but you have the final diagnosis when you put P16, and if that's coming positive, you identify that in a lesion, then you know for sure that this is a transforming HPV and we'll have to treat it. So now we have this understanding very well. We have taken this chart last time also, that there is a complete regression also in CIN1. But this is the Suringa trial. SIN2 had SIN1 had a regression to 60%, SIN2 to 40%, SIN3 to 33%. Nevertheless, progression has been quite high in SIN3 and to cervical cancer. Even SIN1 1% has gone into cervical cancer. SIN2, 5% has gone into cervical cancer. So but you can afford to, keep this SIN1 under observation. You don't have to go and treat it, but you keep her under observation. Do her HPV, do her pap test, understand the case. If there is a SIN2, put an IHC tumor marker and try to understand whether this is going ahead or it is regressing, or it is so you come to know if there is a P16 positive, then this can progress. So these are the cases you can go for treatment. And if it doesn't want, you can just wait. But usually SIN2 plus and all we treat, irrespective of what the tumor marker is. Now we have over here the onset of cervical cancer from the time of HPV infection is slow and might take more than 15 years, allowing for an extended period of screening to intervene early. So you have this extension period. So this is your HPV infection. It's take a long years, you can see. And pre-cancer are seeing only in this age group, and cancer still further this age group. So you have a long period whereby you understand this chart and you understand this transformation and you treat them, so it will regress. See, and as I told you, it's a histopathological diagnosis, and you have this transient infection. We pick it up by cytology, but then definitely colposcopy guided by biopsy is the gold standard. And this also we understand very well. Now, so we are in the green zone so that we don't want our patients to go into the red zone. So for being in the green zone and to understand what we can do for the patient at the precancerous condition, or that's exactly the basis of preventive oncology. And you have this understanding with VIA, PAP test, and HPV test as well. These are all paradigm shift. And we are now in a position, we are doing HR, HPV, we are doing mRNA, we are doing immunohistochemistry. We are understanding the case much, much better than we used to do a decade before. And why molecular test is because it gets a clear-cut understanding. It's 100% negative predictive value. There's no confusion in the results, no subjective variation. Standardization is there because we are using clinically validated tests. It's cost effective because you're going to do it once. You don't have to keep on calling again and again. And you can have a longer time interval between the two tests, about 5 to 10 years. It helps in better triaging and understanding. So screen with usually with this, and then I just told you how we take up screen, triage, and diagnosis. So we have over here, say if there is an infection with HPV, there is a DNA replication, there is E6, E7 gene expression, and cell cycle deregulation. So with HPV DNA, you will understand that, okay, the patient has a infection. With E6, E7 mRNA, you will understand, okay, there is some cell gene expression is there with which can go into tumorigenesis. But with definitely with P16 Ki67, you will know, yes, for sure, cell cycle deregulation has occurred, and this case can go into a cancer. So definitely over here, you will be very, very meticulous in treating her completely. So that's how we understand, and that's how the team approach. Now going to, can you rely on a PAP test? PAP sensitivity for cervical disease is poor. And this is from the journal which I have brought, and so many journals have quoted their conclusions that precancer is likely to be missed out in 1 out of 2 cases due to low sensitivity. So about HPV test results, if there is a negative, then definitely there is a very high NPV value, and 99.9% you are certain, but 0.1% you leave, you are not certain. Why? Because 0.1% it can be non-HPV related cancers also. Then positive does not mean it's a presence of cancer. That's one thing. So whenever you have started using HPV as a primary screening test, you should know how to even counsel these patients. Because if they come positive, doesn't mean a cancer, right? So you will have to counsel in a very soft way, gentle manner. Don't make them scared. Repeat test may be needed after a year. So the HPV test has a lot of benefits. So it detects HPV DNA with a clinically validated test, and the confidence of 20 plus years. It's a real world safety, you can really have that understanding. Internal cellular control is there, no cross reactivity, guidelines are supporting genotyping, workflow automation is there, high NPV value, and, and regulated approved for regular screening. Now, this is from this NEJM journal where Shankar Narayanan's study was put up in the Barshi, and it showed that, HPV testing, that these are the deaths. You can see that deaths due to different thing has been very high in 8-year study. But with the HPV, it is the lowest. And with cytology and VIA, and this is a control group, it is almost, it's not much of a difference. So that's what makes you understand that, HPV is the way forward of taking up cases. Which are the tests which are validated? Digen is validated. HPV by PCR, the validated ones are Roche ones. And then HPV mRNA. Normally, you get PCR में non-validated test also. Be very careful to use Cobas or Cevista. They are the validated ones. Now, mRNA, Aptima, that's also validated. Now, genotyping are available to identify 16 and 18. Now, when you talk about hybrid capture test by hybridization method, by Digen method and a PCR method. Now, there is a 94% increase. You can see these are the 16 published data, some meta-analysis studies, which has given an understanding that HC2 are more sensitive than PCR for detecting 2 years cumulative SIN3 or cancers. When you talk about an HC2, it has a clear-cut understanding. It gives you a result in RLU, relative light unit. Same, above 1 RLU is considered to be positive. It's a ratio. So they have an understanding that if the viral copy numbers are denominator 5,000, and if there are more, then it gives you a ratio. Say above 1 might be 20 RLU or 10 RLU. It gives you the copy numbers understanding. And so it has a clinical relevance. So this is a clinical HC2 cutoff is 5,000 copy numbers. Below that, they have said that there is no relevance for the clinically, for a clinician. So I'm not worried if it's at a 0.8 RLU or 0.5 RLU. It is less than 1. So if there is less than 1, I don't have much. This is all from the studies which has come up. Whereas a PCR will even detect this, even 10 RLU, 10, this thing also it will detect because it is quite, it will catch up even those low copy numbers. Now, low copy numbers doesn't have any relevance to disease or, it is clinically irrelevant. It's only laboratorily relevant. It's not a clinically relevant one. And hence, when you use a COBAS and all that, it has a relevance. It has a cutoff, a limit of detection of 600 copy numbers. So there also it is, it increases the probability of detecting the high risk ones. So HPV DNA by hybrid capture technique by Digen is really good. I have been using that only. And whenever I have to do a genotyping, I do Roche. So, and also I've been doing mRNA. My studies in mRNA are also quite famous. And so they are, this is how you understand an HPV. This is a cervical. So this is for, only Digen. Here you can't use co-test. So don't use this for co-test. Only for HPV HC2 is okay. If you want to do a co-test, you can have this kit for co-test. And I have also shown you how to take a brush. Now this brush has an endocervical part and an ectocervical part also. So you use that endocervical brush inside, you fix it, and then you rotate it 5 times, clockwise or anti-clockwise, whatever way. And finally, you will drop it onto that collection device, and that's how you will send to the laboratory. So squash it and send it to laboratory. Now, what is the GCPR saying? That if there is an HPV positive, it is positive, what you can do? I normally take up this path, Normally, we, in our 30 centers pan-India, we have an SOP, I told you. We normally do with hybrid capture and then we genotype it if we want to genotype it. And we, if the patient is affording, then we do co-test. If she's not affording, we do an HPV test for her. That's our standard methodology of understanding the disease. Then say with genotyping 16-18, definitely we do a colposcopy. Now, suppose we would have done a co-test, I'll come to that. Suppose if she triaged it with cytology, more than ascus, you will do a colposcopy. If it is NILM, you will just repeat her test after 1 year. Otherwise, if we have a patients which are very, very poor, then we triage with VIA and try to find out whether there is a need. And otherwise, if it is negative, collar attach 5 years. So what we do with the co-testing is there can be 4 scenarios. Both can be negative, we call after 5 years. If HPV is negative, cyto is positive, and if it is more than ASCH or HCL, then we go for colposcopy. Or ASCUS or LCL, we can still wait, repeat our test after 1 year. If it is HPV positive, cyto negative, we have 2 options. Either we do a genotyping and understand 16-18. If it is positive, we go for colposcopy. Otherwise, if it is, we can otherwise even repeat after 1 year and then see. And if it's HPV, both are positive, definitely colposcopy. Now, HPV-based newer methods are there. We have a vaginal self-collection device with Delphi device. E6, E7 mRNA with Aptima or Oncotech. I was doing a lot of study with this Oncotech Incel DX. I think I would be the, my study would have been the second study. It was going concomitant along with the same study in Delhi. So parallelly, I was doing this study in the private sector and they were doing in the government sector, and we found good effectiveness, but unfortunately, it is not available in the country now. Aptima has come up, and we can use that. Then we have methylation study, and then we have this topo markers, and these are also coming up, MCM2 and topo T and all. Now DNA methylation also, one of the company had approached me to do their validation. It's quite an expensive one, and it cannot suit for our Indian population. So WHO has come up with the understanding screen, triage, and screen and treat, screen, triage, and treat. With screen and treat, they are saying HPV DNA followed by treatment. Screen, triage, and treat. If you are doing the screen, triage, and treat, see, in the primary screening, if there is no lesion also, they are treating. But that is in screen and treat programs. They just see with the VIA whether there is an eligibility factor. They see the SCJ, which type of TZ. And even if there is no lesion, they treat. If there is TZ2 or TZ3, small TZ2 or TZ3. And if there is a, HPV 16, 18 and all positive, they do a treatment. So this is the first approach. And they call after 1 year. In the screen, triage, and treat approach, if the NAT is positive, HPV DNA positive, and suppose if you do 16, 18, by secondary triage, you can do genotyping, or you can do VIA, or you can do colposcopy triage or cytology followed by colposcopy. Now, suppose if her HPV DNA NAT test is positive, but her triage is negative, then you can just wait. We do not require treatment. They would require a follow-up. Maybe 1 year, maybe in a patient of what they are recommending. In a general population, you call her up after 2 years also is okay. Because you have triaged her with all the remaining tests, which has come negative, no problem. And if it's an HIV patient, you call her up after 1 year. Now, if after a positive primary screening result, if both HPV NAT and triage tests are positive, then you will see for the eligibility criteria for ablation at the same visit or at the second visit. If she is not suitable for ablation, you will call for LEX or LEAP. And if she is not suitable for both the things, you will refer for further evaluation. So understanding this much for screening is prudent, and understanding again that HPV is a root cause for cancer. We have developed, vaccination is available. There are a lot of newer recommendations coming up for vaccination. Let's see all that now. So Ian Fraser, an Australian scientist, got the award as an Australian Year of the Award in 2006 because he developed this. Now, what they have understood is HPV does not discriminate by age. Let's see this. This was when that Australian paper, you can see that come up from this 2004 paper. I removed this, that it is like cumulative risk for HPV infection in an age group of 15 to 19 is 42%. In an age group of 20 to 24 is 36.9%. 25 to 29, 30%. Similarly, it is just dwindling down. So whenever you talk about vaccination, you will be giving it at before the age of 14. Again, it has a high antibody prevalence, and it also stays back. Immunity is very quite high. So even before the first sexual debut she is getting, it is best. Now, the risk of progression from CIN1 to CIN3 and cancer, this but increases with age. So you can see the risk of development of CIN3 or cancer. If it is in the age group of less than 20, the risk of developing from CIN1 to that is 0.4% only. In this age, 20 to 29 is 1.57%. In this age of more than 30 is 2.7%. So the risk of progression from CIN1 to CIN3 increases with the age. And that is another reason why we want our girls to get vaccinated at the earliest. Now, HPV vaccination of girls, the key for cervical cancer elimination in LMIC countries. So what they have seen is, if they do not do, then there is a status quo. It's like the for cancer. Oh. Now, this is only vaccination. So this chart is vaccination. This chart is vaccination plus 1 lifetime screening. And this is vaccination with 2 lifetime screening. So you would see in this case, it is less than 4 cases per 100,000 women. And here, if there's one-time screening with vaccination, less than 10 cases per 100,000 women. And if vaccination alone, then it is little high. So you have seen that high coverage can achieve elimination within the country. More than 45 million deaths can be averted by vaccination of girls. Adding twice lifetime screening prevents further 14 million deaths, which can be a help in the elimination in a decade. So we have this understanding, and this has come from NEJM Journal 2020, the latest one. HPV vaccination at the young girls, they strongly reduce the cervical cancer. So this is from the Sweden trial, which they said that 1.6 million female girls At the age of 10 to 30 years, vaccination was done less than 17 years, 83% reduction. At the age of 17 to 19 years, 11% reduction. More than 20 years, vaccination, 6% reduction. So compared to the non-vaccinated population, HPV vaccination less than 17 years will have 88% reduction in invasive cervical cancer. And more than 17, if cumulative, this is cumulative, it will be less effective, but still there is a reduction by 53%. So this is an unvaccinated population. This is the vaccinated population at 17 to 30 years, and this is the less than thing. So you will see that it is really less. You don't have any cancers, and is at the minimum if you give it at the earliest. So there is also a study from Australia which has shown that it declined, all these infections declined by 86%. Then 92% there's a decline in genital warts. 34% decline in LSIL. And histopathological proven SIN2 plus and SIN3 plus, you can see the decline by giving vaccination. Now, understanding the fact that genital HPV is the main cause, 4 out of 5 women will have an HPV in their lifetime. And we also know that HPV is also responsible for all these factors as well. So giving vaccination truly helps all that also. Normally, why you give a vaccination? Because so much of people have HPV, but HPV doesn't cause any systemic immunity, for it. So there is no innate immunity. That's the reason you have to give vaccine. It's so this is a local immunosuppression only. See here, there is no viremia. There's only local sometimes inflammatory reactions. Doesn't have any inflammatory or no danger signals, and hence when you vaccinate with a VLP virus-like particles, that triggers the antibodies in the blood and the site, and then these antibodies flow to the site of infection. They cover up these capsids, and these capsids are the main antigens, and they prevent this entry. They neutralize the virus and prevent the entry into the cells. In a word, these are the guidelines from various organizations, and they have understood one thing is, quadrivalent vaccine is efficacious even in, this is from the Futura 3 trial. And when they did a trial for Future 3 trial for mid-adult women, and they found that, there is a very good efficacy, even if you give it for a older woman. That is what they found from 24 to 45 years. So they were 89% efficacy against persistent infections in or condyloma, 92% efficacy against this ascus. And if you give, LCL or worse, there is definitely, and if it is related to those viruses, it is definitely there. Now, understanding the fact that in our country and all, no, we do not have any vaccination protocol in our country, but these other countries, Latin America and South and all this America, they do have it. Even in Australia, even in Sri Lanka, they have introduced, you see, and the rest of Europe also. WHO immunization paper, which is released latest ones, is showing the primary target group should be in the age group of 9 to 14 years, secondary target group above 15 years, and you can have multiple cohort groups as well. GCPR also is recommending that you give a target age for 9 to 14 years, catch-up vaccination 15 to 26 years, in boys 21 years. Now, there's various organizations say when you have to give it, but what our understanding basically is you can give a lady, and you give, so older women also you can give. In Futura 3 trials we saw that is the 84% protection. So whenever an older lady comes to you and asks for vaccination, you can tell her this very clearly that you don't get 100% one, but definitely yes, you can get around 80% of protection. So the FOXI recommends this age group. And we normally say that it's always best to vaccinate below 14 years. So age of vaccination is 9 to 14 years, usually 10 to 12 years the girls comes to us. You can give a catch-up vaccination till the age of 45, but normally we say WHO recommends till 26 years of age. Now 3 doses, 0 to 6 months for quadrivalent and 0, 1, 3, 6 for bivalent, 3 doses. When you give it below age of 14 years, it is 2 doses, 6 months apart. Now we have this LTFU trial, that is long-term follow-up study of quadrivalent vaccine from 4 Nordic countries. And you see Feature 1 trial, Feature 2 trial, Feature 3 trial, which definitely showed the efficacy. And these trials made us understand that it is very easy and it's a very effective way of preventing these infections. And then we came up with nonavalent vaccine. Now, then they understood that they added up nonavalent vaccine. In nonavalent vaccine, which are the other strains, 9 strains are there. That is 7 high risk and 2 low risk. And so they are seeing over here 31, 33, 45, 52, 58. This is the study. They saw the endpoint results. If they put quadrivalent vaccine, if they put nonavalent, quadrivalent, what is the efficacy? What is the endpoint is SIN2, WIN2, and VAIN, and these are all SIN, WIN, and VAIN, and 6 months persistence. And you can see the results compared to quadrivalent to nonavalent. So 1 in 6,016, 30 in 6,017, 3 and 103. See, everywhere the efficacy increases by putting a nonavalent vaccine, and nonavalent vaccine now comes up with 6, 11, and rest of the 7, that is 16, 18, 31, 33, 45, 52, 58. Now, what is the difference here? See, Cervarix and quadrivalent, they are using adjuvant is monophosphoryl lipid, ASO4. And here they are using aluminum hydroxyphosphate sulfate. Here they have increased, in quadrivalent, they have increased this aluminum hydroxysulfate adjuvant. They are using baculovirus insect cells. Here they are using yeast cells. And these are all, what is produced is VLP, virus-like particles. Indications of nonavalent vaccines are prevention of precancerous condition, carcinoma, adenocarcinoma in situ, prevention of CIN123, VIN, VAIN, anal warts, and anal cancer and genital warts. Now, a frequently asked question is, what about nonavalent vaccination in those previously vaccinated with quadrivalent and bivalent? Understand, the 16-18 has a cross protection also. 16 has a cross protection against 31, and 18 has cross protection against 31, 33, and 45. So if you would have given your patients a quadrivalent or a bivalent vaccine, you would get a cross protection against these also. So what is just remaining? What is remaining is 52 and 58, which is very low this thing. So you don't have to actually switch to another vaccine, or there is no need actually for any other vaccination if we would have done this. So this is a frequently asked question. Now the special situations like 2 doses are there, minimal 6 months apart. So that has to be there. So between 2 doses recommended below 15 years of age, at least 6 months apart, that dose schedule has to be, interval has to be there. If the time period is less than 5 months, many a times what happens, she's flowing to somewhere, she's flying to maybe Canada, US, she wants to take her vaccine and go. But then the 3rd dose is recommended. If she is so much hell-bent on, and they see that 2-dose schedule, then only these girls get those, some university takes them. So in such cases, then you will have to have the 3rd dose schedule. If the period is not more, and it's always better that there is a little bit more. Doesn't matter the 6 months, she can come and take it at 12 to 15 months. This is also okay. Now, there is again a SAGE recommendation coming up on 4th, 11th April 2022, latest one, there was a SAGE recommendation for WHO stating that 1-dose vaccination also will be okay. So what they said that 1 or 2 doses scheduled for primary target from 9 to 14 years, they can give 1 or 2 doses. 2-dose schedule from 15 to 20 years, 2-dose with 6 months interval for a woman older than 21 years. So this is coming up with a 1 dose below 14 years and 2 doses till 21 years. Now, these recommendations are coming because they are understanding the fact that if it's an LMIC country and the vaccinations are not freely available, it's costly, then how do you have a universal immunization coverage? That is why all these things have come. And they also come up with a study which was quoted by many 4 or 5 studies they saw before coming to this conclusion. And in that, we had this Partha Basu study also, that Bihar study, which showed that only girls who had taken only 1 and it interrupted. They couldn't take ahead because the vaccination stopped there because of some non-related problems. But still the immunity level, even after 10 years, didn't dwindle down, even with 1 dose. So that was also one of the important things to get this recommendations. Now, SAGE recommendation says, but still it has to come up, that SAGE has just recommended, WHO has to come up in the position paper. Now, they are, the other day, Pata had given me a mail stating that, Priya, why don't you have a FOXI recommendation for 1-dose vaccine when WHO has already come up with it? Now, WHO has just come up, and we from FOXI, we have also written, and let's see if we can come up from FOXI recommending 1 dose. But till then, let's keep that 2-dose schedule. And now Sage has also understood one thing. Sage also has given one recommendation. 2-dose schedule may, it's like we normally say 6 months, right? But then we say that if she doesn't take at 6 months, catch up can be done till 12 to 15 months. They are more flexible, stating that even 3 to 5 years may, if you give second dose, is all okay. So that's what they say. But whenever there is an immunocompromised girl, you give 3 doses. Now, what are the other special conditions? That can it be co-administered with other vaccines? Yes, it can be. If it's pregnant, what will you do? You won't do her MTP, but you won't give her the second dose. You will call her up after pregnancy. In lactation, you can give, it's a VLP only, where virus-like particle doesn't have any problem. Now, talking about the adverse effects, there can be small headache, fever, nausea, dizziness, and all. Sometimes only syncope, but these are very rarely notified. Associated with tonic-clonic, this thing, anaphylaxis, all very rare. Now, another thing to understand is therapeutic vaccines are coming up. PEPCAN trials are quite high. If anybody's interested, you can go through these trials. And they have seen that they have reduced, viral loads have reduced. They are using L1 and E6, E7 as their antigenic factor. But there are a lot of challenges in HPV vaccination. Let's see. Now, even a healthcare provider says, I'm an OBGYN, it's a domain of pediatrician, why should I talk? Then screening is enough. Why do you do a vaccination? Counseling is difficult and you don't have time. And then you say that, do I need to vaccinate even if my patient is seropositive? These are all the questions among healthcare providers. Among patients, it is, my daughter is too young. Now I'm old, I don't want to take, or I'm worried about safety, I'm breastfeeding. Will it last long, or what's the cost? So let's see how to address this. So one thing is counseling. Go with small messages. Don't give a very heavy knowledge. Give small messages and leave it. Give those pictorial things in your lobby. Serotype, do I vaccinate even if the patient is having HPV? Now, understanding one fact is we might be HPV with one virus, this thing, strain, but we can have other strains, and we are also giving this as a protection for the future infection. So that's one thing very, very important. So definitely sexually active women can benefit from HPV vaccination. My daughter is too young. Why should I give? The 5 reasons for giving your daughter at a younger age. First of all, only 2 doses are required. It's a prevention vaccine. And you see, if it given at the early age, the antibody levels are there. It's remaining. And 98% efficacy is seen in a naive population, 15 to 26 years. And if you give at this age, 100% for all vulva, vagina cancers as well. Now, they say that's only monogamous relationship. I don't require a vaccination. That's a study which showed that even after the monogamous relationship, in 1 year, there was a 30% positivity for HPV. And after 3 years, 50% positivity for HPV. Now, cost is also reduced. No, if you give only 2 doses, 6 months apart. And if it is an older age, she says, I don't want to take a vaccine. But then you have to say, talk about the safety factor. And safety factor has proved beyond doubts. All these licensures have said that, no, it is safe. There is nothing to worry about the safety. And talking about breastfeeding, it's not a live vaccine, so it doesn't matter. So VLPs it's a very safe one. There was a trial done when they said that there was no adverse effect with the neonate or with the mother as well. So there are guidelines which are set safety for lactating women. Talking about the sexual abuse here, 3 doses are given, with the first dose given at the time of initial examination. And then talking about abnormal PAPs and positive HPV and previous HPV lesions can be vaccinated if they desire. However, first of all, they have to be treated. They have to be counseled, and it's not a therapeutic vaccine. So, they have to be counseled for that. And among the males, now people are asking many questions about what is it. So if you give for males, it's in herd immunity. So when the percentage of women getting vaccinated becomes 30 to 40%, it's wise to give vaccinating males, because that is where there is substantial enhancing impact on trying to protect those women who are not now vaccinated. So it can be recommended. So the recommendations goes is 11 to 12 years for boys. And, you can give it till 21 years if not vaccinated. But now they are saying that even men from 22 to 26 years can be also vaccinated. I told you safety profile is there. There's nothing much to worry with all these adverse effects also, but not much to worry. Limitations for use of HPV vaccine does not provide protection against diseases from previously, definitely, the previously whatever the patient had. It is not, it's just a prophylactic vaccine, not a therapeutic vaccine. So that's the limitation. It does not eliminate the necessity to continue to undergo cervical screenings. So screening has to be done. That's one thing which we have to emphasize. The advice to get vaccinated early, but cervical cancer usually prolongs late in life. So what they have seen is 14 years, this was a study, long time, I took it up, it's a very old one. It came in 2018, stating that 14 years of vaccine protection was there. Cost, 92 to 95% of the physicians think it's costly, why should you waste? I mean, people don't speak about it. Now, there was a study which said that, many of them who were unvaccinated women felt that our physicians didn't recommend. If they would have recommended, we would have got motivated. So the cost barrier went with the physician, not with the patient. And further, say yes to vaccination. What is the impact of screening and vaccination on cervical cancer elimination? Let's see this. So this is where, the screening is done with VIA. Once, this is done twice, this is done thrice in the lifetime. This is vaccination, and this is only vaccination. Let's see. Only vaccination has prevented 44% of cervical cancer, but thrice at least VIA along with vaccination has prevented 61% of cancers. If it is twice VIA and vaccinations, 56%, and later only once, 52%. So definitely, I come to the end of my talk. All these things I have brought it from my sorry, got it out. I've brought it from this test books, all this thing, and it's all there. So we have been conducting lots of camps, and today is also my fellowship program going on. So dear friends, it's not a dead end. We do have an alternative ending, and we have to fight cancer together. It has to be at all levels where we have to do all the things. We have to join hands, and we have to unite to get cervical cancer Mukt Bharat. So thank you very much for this complete four whole series, web series. Thank you very much.
Good evening, Priya Madam.
Good evening, Dr. Anupama.
You have given an in-depth insight of the HPV infection, the progression of disease, and a very detailed information regarding the cervical cancer vaccine, HPV vaccine, both the bivalent, the quadrivalent, and nonavalent vaccine. So, but there are two questions, madam. Are we taking questions?
Yeah, we are.
Yes. So there are two questions. One is from Dr. Fadkin. Is triage test and co-test the same terminology? And another one is the components of HPV NAT test. So
triage and triage test is, you do a primary test, you see this as positive, then you triage. Co-test is you're doing both the tests together, PAP and HPV. That's co-test. Now there's something called as reflex testing. What is reflex testing? You do one test, is coming as positive. You ask the lab to do another test. Say you've done an LBC, it's come positive. You are asking the lab to repeat an HPV. So you're not calling the patient again. So that's your reflex testing. Now, if I have to have the co-test in the same scenario, I have called her up for a PAP test. Her PAP test has come positive. And I call the patient again, take her sample again, and then triage it with HPV or triage it with whatever. So triaging methods can be anything. Like if I do, for me, a triaging method would be, I do a primary HPV, I triage it with 1618, or triage it with LBC, or triage it with E6, E7 mRNA, those things, or triage it with IHC tumor marker. So they are triage ones. We can call and do it or take the sample again. But if I have to reflex it and I have the sample with me, then I can only reflex it. So these are the two terminologies. Co-test means doing both the tests together. And now Seema Tripathi has asked components of HPV NAT test. That's a nucleic acid amplification test. And they are the DNA test or mRNA test.
Thank you so much, Dr. Priya Madam. It is very nice to listen to your talks and listen to your elaborate presentations on cervical cancer, and the work that you have done is a commendable work. I look forward to be associating with you in future soon. Thank you very much. Thank you very much, Dr. Priya.
Thank you very much. Yeah.
I think I'll hand over the session to Dr. Rujita. Dr. Rujita, are you there?
You're not audible, huh, Rutuja? No, you're not audible at all.
Rujita, I think Sangeeta can take forward the proceedings.
What happened?
I think Rujita is not audible. Are we concluding the session?
Actually, Rujita has prepared 1 minute. Huh?
Okay.
Yeah, sorry. Technical problem. So log in from this.
You're logging from both the device, so that's
Yeah,
possible.
I have logged in from the mobile now. So extremely sorry for the technical problem. Excellent presentation, ma'am, and all the four series, all the four lectures in this series were exceptionally good and I think super hit. So once again, we thank you, ma'am, and we look forward to your association with the NOGS and looking forward to many more such web series and lectures from you, ma'am.
Yeah.
Sangeeta,
Thank you very much.
you want to conclude? A vote of thanks.
Thank you, ma'am. Thank you very much. Madam, the bottom line is we should screen everyone once by HPV, right? And whosoever asks us, then there should be vaccination drive, right from the adolescent age.
Whosoever nahi, apna khud pe bhi we start counseling, you know. And I will request all of you, you go through that. We have brought 8 videos, no, from our committee. Is there in this Foxy website.
Okay.
So kindly, you know, download them. We have made it in 8 different languages. You can play it on your lobby and it's done for your public awareness only.
Okay, ma'am. Okay. From the Foxy website, we can download.
Yes. Yes.
Thank you very much.
Thank you. Thank you, everyone.
Okay, ma'am.